Welcome back. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for being here. My next special guest, Dr. Ron Friedman, eye surgeon and ophthalmologist. Dr. Friedman, thanks very much for being here.
My pleasure.
Dr. Friedman, I want to talk a little bit and teach our audience about what your day is like as an eye surgeon and ophthalmologist. Tell us a little bit about your day.
Well, it's a long day. I start at usually about 8:30 in the morning on days that I don't operate. An ophthalmologist practice is generally filled with a lot of patient examinations. So we break our sessions up into a morning and afternoon session, and in the morning we'll see anywhere from 20 to 30 patients, and the same thing in the afternoon. Many of these examinations are longer intake, first-time patient examinations where we have to do tests for glasses, take a history, and go through the routine examinations that examine the pressure, the lens of the eye, and then, of course, look at the back of the eye. And then many of my examinations in between are with patients that I have seen for many years. My practice is 25 years old. I have several patients that I've seen for most of those 25 years where we're monitoring various specific conditions. The most common ones would be the development of their cataracts, the progression of their glaucoma, diabetic retinopathy, or macular degeneration. Those are the most common eye diseases we see in a community such as this, which has a large aging population.
Well, I think that it's a difficult training program and very selective to get through, or the selection process is very difficult. Tell me what the training process is like from, say, college to get to be able to be an eye surgeon.
Well, after college, you have to go to medical school, and most medical school programs are 4 years. Following the 4-year medical school program, normally you will have been accepted to an ophthalmology residency program. We apply during our last year, as you probably did for plastic surgery. And before they take you into the minimum 3-year ophthalmology training program, they want us to have a year of general medicine, because as ophthalmologists we have to understand and be able to have a good familiarity with the basic diseases of the body, such as diabetes, hypertension, and connective tissue diseases, cardiovascular diseases. So at 4 years of college, 1 year of general medicine, then 3 years of ophthalmology training. In addition, many people will go on and do a subspecialty year in certain areas such as retina or cornea, but the most ophthalmologists are just general ophthalmologists who just do that training.
So once again, everybody, of course, finishes high school, and then it's 4 years of college, 4 years of medical school, at least 1 year of general medicine following that,
right,
and then at least 3 years of residency in ophthalmology following
Correct.
that.
Yeah.
That's a lot of years of training.
Yeah, it's 12 years after high school, basically. So if you're lucky, you get out when you're around 29 or 30 years of age.
And then you get to start the real work.
Then you start to practice.
So again, let's talk about some of the things that you do in your practice. You take care of cataracts, and you take care of the diabetic who has eye problems, and you take care of glaucoma.
Right. As an ophthalmologist, we differ from optometrists who can diagnose these diseases, because we are allowed to prescribe a great deal more medications, and of course we also do surgical procedures. So in a busy general ophthalmology practice, I had to devote at least a day towards surgical procedures, which in my practice is set aside as 2 separate mornings that I do surgery. A large number of my patients that I see, that I've seen for many, many years, are followed for a condition called glaucoma, because it's a very common condition in general population.
Now, Dr. Friedman, see, another opportunity I have for hosting this program is I get to learn a lot, and glaucoma is one of the things we're going to talk about today. So how is it that you get involved with the care of the patient who has glaucoma? And I guess I'm going to learn a lot here.
Well, that's a great question. And if you learn nothing more, and if the audience learns nothing more from this interview, it is that you have to have routine eye examinations, because there are no symptoms of glaucoma until the sight goes out. And the nickname for glaucoma is thief in the night. And the reason that is, it is what we would call an insidious disease. Pressure builds up in the eye and gradually starts to cause deterioration of the nerve at the back of the eye. I have some pictures here which I can use. This, of course, is the front of the eye, and we would not see anything different at all in the front of the eye in a patient with glaucoma. We wouldn't see tearing, we wouldn't see any clouding. And if we look at a cross-section of the eye, we see that there is a nerve at the back of the eye, and in the front part of the eye, there is a chamber that creates fluid. Well, what happens is, and there's a path of the fluid that flows through the eye. In glaucoma, the pressure builds up in the eye, but not to a point that the eye necessarily becomes painful, but to a point when the nerve starts to deteriorate at the back of the eye. And as the nerve loses fiber, the peripheral vision becomes darker and darker from the sides. And people very commonly will come in complaining that all of a sudden they're starting to not see out of the side of one of their eyes. And by that point, unfortunately, it's often too late.
So essentially, it's pressure building up inside the eyeball, or what we call the globe,
Correct.
right?
Yes.
It's pressure building up. So how is it that pressure builds up? Why is it that a person...
That's a great question. Well, glaucoma is a disease that is strictly of the eye. It can have many secondary causes, but the basic type of glaucoma, which we call simple glaucoma or chronic open-angle glaucoma, we don't really know why the pressure builds up. We have an idea that, again, in part of the eye, the fluid is being made normally, but in the area that's supposed to drain the fluid, it's not draining normally. So it's as if the pipes that drain the fluid of the eye are getting slightly clogged.
Now what's the fluid that you talk about?
Well, there has to be fluid in the eye that carries nutrients. An eye can't just exist without turnover of fluid, because every tissue of the body needs to have oxygen, glucose, minerals, and metabolites brought to it. And the eye is no exception. Now, most of the eye, the fluid circulation is relatively small, but in the front part of the eye, there's a lot of turnover of fluid, a lot of metabolic activity.
Okay, now Dr. Friedman, now if you take, say, a muscle in the body, it gets a blood supply. The blood goes in and delivers oxygen and nutrients and carries out CO2, carbon dioxide, etc. But that doesn't happen exactly in the eyeball.
Which if we had blood flowing in and out of the eye, it would cloud our vision all the time, so that doesn't work. So there's a special fluid that's made in a part called the ciliary body, which is here, that does have a lot of blood supplied to it, that supplies the nutrients by a clear fluid, because to see we have to have clear fluid flowing through our eye, and this clear fluid provides the nutrients for the lens, for the iris, and also for the cornea, the true window of the eye.
Okay, so what's the average age that a person might develop glaucoma? Can young people get it? Is it just the older patient? Who gets glaucoma?
Great question. Unfortunately, you can get glaucoma at any age. Now, the most common glaucoma does not occur until people are over 60. And the incidence of glaucoma in that population is actually someplace between 1 and 10%, which is a rather high proportion of people with the problem. I see frequently people in their 40s and 50s who have never had eye exam coming in with glaucoma. It's not a very high percentage, but because people don't necessarily get their eyes tested, it can become more advanced at that age because they're not getting routine eye exams.
Now, is glaucoma associated with other medical conditions like hypertension or diabetes or cardiac problems, or a person can have glaucoma and not have any other medical problems?
Yes to both questions. Yes, they can have glaucoma without any other associations, and in fact that is the most common type of glaucoma. Simple glaucoma, no other problems. But we know that diabetics do have a higher incidence of glaucoma, and you can also get glaucoma in association with other eye disease. So there are multiple causes for glaucoma, and when a new patient comes in with a new diagnosis, we go through a few extra tests to make sure that they don't have any of these other associated diseases, either associated eye diseases or associated systemic diseases. Most don't, and then we just treat them for the rest of their life as if they have chronic simple glaucoma.
Okay, so Dr. Friedman, let's summarize what we talked about thus far. Glaucoma is an abnormal condition where the pressure builds up in the eyeball, in the globe, and the pressure gets to be so high that it starts to injure the nerve, the optic nerve, which is at the back of the eyeball.
Exactly.
And it may not necessarily have any symptoms. It's not painful.
Correct.
It can be asymptomatic, as we say, and it's diagnosed by the ophthalmologist or the optometrist who notices by testing. How do you notice that the pressure's higher?
Well, we have a little device that we push against the eye, and it's called a tonometer. And even though the pressure is inside the eye, we can put a little device to the front of the eye, just like I could touch your eye and feel the pressure by pushing into it and get an idea of what the pressure is. It looks, old-timers like us would remember what the tone arm of a record player would be, where there's a little tracking weight that measures the arm force. It's an identical device. I'm pushing something against the eye after putting numbing drops in, and I read the pressure on a dial.
Okay, and I believe that there's a more modern way to test. Is it with a puff of air, or?
Well, actually, that's another alternative, but it's not more modern. In fact, it's actually less accurate, and it's less comfortable for the patient. Most of us now will put an anesthetic drop in and do what's called the applanation with this small little applanation device. You may be thinking years ago there used to be a plunger device where we had to lie someone on their back, and that was called a Schiat tonometer. That was quite a bit more of an ordeal than the modern day tonometer is.
Okay, so we've talked about what glaucoma is. We talked about how you diagnose it. Now, what about the patient that you discover it or diagnose it? Like, how do you treat it? What goes on for that patient?
Well, there's three basic modalities of treatment for glaucoma. There's medication, eye drops, or laser surgery, or conventional surgery. Most people, when they're first diagnosed, and for many years after their initial diagnosis, are treated with ocular medications or eye drops. The reason is they are very reliable, they're very time-tested, and there are now multiple different types that we can usually accommodate a patient who has glaucoma with maybe just 1 or 2 eye drops a day in each of their eye, and monitor to see if the glaucoma still continues to progress.
Now, how do those eye drops work? I know, this program is for the public and it's not for other doctors, but I'm interested in the mechanism of how do eye drops decrease the pressure in the globe?
Another great question. Most of them decrease the pressure by slowing the fluid that's coming out from the fluid device. Since we know the fluid is not draining as it should, it's easiest for us to find medications that slow down the amount of fluid being made, and therefore the pressure doesn't build up as high in the eye.
Okay, so you start people on medication, which essentially is eye drops.
Correct.
Is there an oral medication, pills to take, or it's eye drops?
There are, but they are not in as much favor because we don't have to treat the entire body with a pill just to treat the eye. And because the pharmacokinetics or the dynamics of how eye drops work are so well studied that we feel very reliable with the dose relationship to the pressure, even more so than with pills, because pills can be obviously absorbed differently by different people.
Okay, so you mentioned laser surgery and you mentioned routine or open surgery, Dr. Friedman.
Correct.
So when does a patient with glaucoma go on to need surgery?
Generally speaking, in most ophthalmological practices, when we define glaucoma to be advancing beyond the ability for the medications to control it, or beyond the ability for the patient to comply with the medications for various reasons, we consider a surgical procedure. Laser procedures are not very powerful for glaucoma. So most of the time, they buy us a little bit of time. So if you can't control the glaucoma with eye drops, we usually go on to a surgical procedure in an operating room.
Okay, so can you give us a summary of the goal of that operative procedure? Do you go in and open up the channels, or do you...
There's multiple different surgical procedures, but the basic procedure is to make a little protected outlet for the fluid that bypasses the clogged outlet that is keeping the pressure building up. So we essentially make a guarded filter in the eye, and it's a very delicate microsurgical procedure with a pretty good success rate.
So roughly, how long does it take, and do they need a general anesthetic, and is it inpatient or outpatient? Tell us something about the mechanics of the surgery.
The procedure is an outpatient procedure, and it takes 20 minutes. We don't have to put someone to sleep because we have excellent local anesthetics we can use. The patient's comfortable during the procedure, and again, the success rate in many populations is 80 to 90%. Now, a lot of patients have the existence of cataracts with their glaucoma. So another area of my interest and the interest in our specialty is combining a cataract operation with a glaucoma operation, or what we would call a combined procedure. And that's a very common modality because the person has both, and if we're doing an operation, we can actually treat both at the same time.
Okay, now, Dr. Friedman, This is very valuable for me, and I'm learning a lot. But talk more about the patient who has cataracts and glaucoma. Like, if someone notices a decrease in their vision, they don't know, or is there any way for them to know whether it's glaucoma causing their decreased vision or cataract?
No, no way for them to know. It absolutely needs to be evaluated by an optometrist or an ophthalmologist. Supplementary tests are often needed, specifically a test of the peripheral vision test and pictures of the optic nerve to see how much damage there is. We have machines in our office that can look at the optic nerve and not only take a picture of it, but do something like a tomography where it actually measures the amount of nerve tissue. And then we look at the cataract and see how thick the cataract is, how cloudy the cataract is, and only then can we come to a real good appreciation of what is causing the vision loss and what we need to do. And sometimes it's a complex decision.
Okay. Now, Dr. Friedman, we have about a minute left. So before we go on to our next segment, I want to make sure we give out your name again and phone number or website, and again your location. And again, I want to talk about how a patient gets to see you. Can they just call and make an appointment, or do they need to go through their optometrist, et cetera? No, that's a lot of questions. So let's go over your phone number.
375-2486. And we have a website, friedmaneye.com.
Okay, and where are you located?
Downtown Monterey.
Downtown Monterey. Dr. Ron Friedman. Okay, now, if someone feels that they need an eye evaluation, or they notice something about their eye, it's painful, or they feel they're not seeing well, can they call the ophthalmologist directly? Do they need to go through their family doctor? Do they need to see an optometrist first? How's that work?
No, they can come directly to us, call our office for an appointment, and most insurance companies will allow payment just for glaucoma examinations if you're over 50 years of age. You don't even need to have another diagnosis or even need to be checked for glasses. So everyone should be checked every 2 years.
Okay, see, in terms of public health and a public service, I want to emphasize this again, that glaucoma can be totally asymptomatic, and in other words, there's no symptoms for our listening and viewing public. There are no symptoms, and if caught early, it can be treated, and if it's not caught early, it can actually take away vision, right?
It's a major cause of blindness in the United States and throughout the entire world, and there are no symptoms until it's too late. So everyone needs to be checked.
So that's an important message. Dr. Ron Friedman, we certainly appreciate you coming. I hope you come by again.
Well,
this is a lot of learning for me. Thank you so much.
Great questions, as always.
Once again, I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. Please stay with us. We're coming right back. Thanks for being here.